Dr. Royal, if I have blockages in my arteries, I'm also at risk to have them in my legs, and
Correct.
smoking seems to make that even worse.
Absolutely. So here, when we talk about peripheral arterial disease, and Dr. Ahmed was talking about clots in the veins, PAD is blockages in the arteries. So it affects 8 to 12 million in the United States alone every year. There's about 150,000 amputations because of critical limb ischemia or blockages in the arteries every year. So how does this develop? It's the same disease process is plaques of cholesterol that build up in the arteries that go to the legs, which is even a more advanced disease with the heart. The legs, because they're bigger organs, much bigger than the heart, they have the capability of producing collaterals or rerouting themselves a lot more. Despite that, the disease continues to progress. So you have plaques that block the flow. Traditionally, we have observed that people that have blockages in the arteries in the abdomen and all the way to the knee, that tends to be highly associated with smoking. If somebody has an occluded aorta or occluded iliacs, we immediately know that this person smokes a lot because it's almost exclusively related to smokers. If it's below the knee, it's going to be affecting a lot of the diabetic population. And the reason why that happens, the sugar goes up in the blood, and what we call glycosylation, which is high sugar in the cells, starts eating through the nerves. And these nerves are everywhere. They're in your skin, which is why sometimes diabetics step on something hot or something sharp and don't feel it. It affects also the nerves that are even in the arteries, and then these arteries don't work as well. So it's pretty significant. Procedures that we do for this, well, naturally prevention, treating your diabetes better, smoking cessation. One of the most important procedures that we use are balloons and stents, which we started with the coronary arteries. We use them for the legs as well. It's a simple procedure. The wire crosses the blockage. We inflate it with a balloon. And if it doesn't look optimal, then we put a stent in it. And we can do that in the legs. Now, if you go back 20 years, when I started medical school, we used to have what we call bare metal stents. And these bare metal stents are great because they're a scaffold. But unfortunately, once that initial part heals, it starts causing a scar reaction. And then this scar reblocks the stent. So in 2001, if my memory serves me well, we came with the first coronary drug-eluting stent, which means that it's a stent made out of metal, but it also has a medication that releases slowly over time. So it produces the scaffold, and then this medication prevents it from reblocking. And that changed the practice of cardiology significantly because it reduced the reblockage rate in a stent from almost 50 or 60% to now 3 or 4% where we have it now. Now, we haven't had this in the legs for different reasons. The arteries in the legs are much bigger, so the stents that we have to use are much bigger, much longer. This stent, which is called the Alluvia Stent, is a stent for the space between the groin and the knee that elutes the medicine over a period of 1 year, 12 months. That data where you see that 92%, 92.5% freedom from TLR, that means that at 2 years, 92% of the people that got this stent did not have reblockage. This is the best data that we have seen in a stent in this space ever. Right now, the current numbers that we work on is 60 and 70%. That's how bad that was. Now, that stent is not available in the United States right now. All the trials were done in Europe and elsewhere, and we're hoping that we're going to have this in the U.S. sometime next year. Now, they use the same technology of the stent, but a little smaller, so that we can use that same stent in the space from the knee to the foot, which is even more delicate. Usually people that have bad blockages from the knee to the foot are the ones that will lose their legs or toes or some part of their bodies. That stent is called Saval. And we're going to actually start enrolling patients for that trial at our hospital. We're hoping the next couple of months. That's a very, very important trial because it's the first time that this stent is going to be used in this space in humans. And it's going to be everywhere in the world, and the U.S. is only going to have 20 or 30 centers. So we're very proud that our vascular center and our vascular program was recognized with this. So we're going to be enrolling patients for that study pretty soon.